Thank you. So, so I'm really excited because this past year has been a really exciting year for the industry. And as she talked about with the new credential, CCMI, Certified Case Manager Interventionist, and how we put that together. So I'll go over all of that through this presentation, but I'm really, really excited for the industry on what we're going to be able to do moving forward and helping people because, you know, my thing is I've been doing this for almost 17 years now, interventions, and, you know, the number one thing that I see that's still killing these poor young adults is their families. So I really think that we need to do more interventions on the family systems and find treatment for the family systems. Because I just got a call yesterday. We were case managing this guy for a year, and it just ended about 3 months ago. And the mother was buying him a hotel room up in New Hampshire, and, you know, which we, again, would not recommend. We wanted him to hit a rock bottom, and she would not do that. And I got a call tonight that he died. This morning. And then the last episode that I did for the show on A&E, the young woman named Brittany, she aired about 3 weeks ago, and she went home last Wednesday, a week ago Wednesday, and Friday they found her dead. And we had a sober living lined up for her. We told the mother during the pre-intervention, do not allow her to come home. Home is not a safe environment for her after 90 days of treatment. So you guys are all doing the great work of treatment, but yet we have these sick family members that are out there that are still willing to, you know, feed their addiction. I mean, I can't believe that this mother, I was so clear. I mean, I nail it home on pre-interventions. I make it so clear. Do not let them come home. It is not safe for them to come home. And this mother heard it over and over. And so I just did one 2 weeks ago for the show up in New York, and the sister texted me on my way here, and she said, my mother wants to send her post stamps in treatment so she could write her boyfriend in prison. And I was like, well, I'm really sad that your mother is deciding to nurse your sister to death. And I said, that's the reality of it, and tell her to watch the Brittany episode because she did die from this, and your sister's next if your mother doesn't stop. So I used to have to sugarcoat it, but I don't think I can sugarcoat it anymore. I think I have to be aggressive like that and tell them, like I told her during the pre-intervention, I would never say, you killed your daughter, how dare you, after she dies. Like I would not say that to Brittany's mother, but the reality is she knew, she was informed. The treatment center told her not to come home. I told her not to come home. The producers told her not to come home, but mom let her come home. So in all reality, it's these families that are really, you know, having the problem and creating all these deaths, in my humble opinion. So let's talk about the 5-year plan. And thank you, doctor, for mentioning that, you know, saying that it's a continuum of care, because it really is a continuum of care. We cannot do this alone. We all need each other. We have to rely on each other, because without each other, it's not going to work. So with the 5-year plan that the doctor diversion programs do, this is what we've come up with. So if you want to see the international crisis, I mean, we see it in the news every day. I think, what is the statistics now? Is it over 140 people a day? Doesn't anybody here? I don't know, I haven't heard in a while, but about 6 months ago, I heard it was about 140 people dying a day. So we all know what it is. I mean, I know there's not 140 interventions happening today in this country. I know a lot of the interventionists, and there's not 140 of them happening, but I know there's 140 funerals happen today. So what we've been doing is, you know, lately it's just not working. You know, for the epidemic to continue to get worse, it's just not working. We got to think outside the box. We got to do something different in our industry if we're going to save some of these people's lives. But if you look at this, when it starts now and it goes to, like, alcohol is the dark red, So in 77, it was a lot more alcohol. And then it goes into the, the late 2000, 2001, and it's less alcohol. But you go to the next slide, so you'll see how it's turning to drugs. So as the years go on, alcohol's dropping, but drugs are rising. And so you see how all the drugs, it's just getting worse and worse in this country of people. I mean, we know. I mean, we all work in the industry. I'm not telling any of you anything that you don't know. What's the yellow? The yellow is the same, alcohol and drugs. So it's just getting worse every day. And these are old. These are only to, what, 2010, 11 or 14? So it's not even that old. I mean, it's years behind. It's 2 years behind. So the reality is that, I believe the addiction's winning in our country. We have so many people. It's one of the biggest industries in the country, but we're losing this battle. So what do we know that works? What works that gets the highest percentage is 4 or 5 programs that I see that are working. So the first one that I see is the intervention show. We've been doing it since 2004. So 2004, the statistic, what it has is a pre-intervention, intervention, and 90 days of treatment. That's what the addict gets. And there's been some studies. If you go to Independent Coalition of Treatment Providers, there's a study where there's 3 different studies that if you bring the family's involvement into recovery, it raises 50%. So I believe that's why during the pre-intervention we get such a higher success rate. Business Insider says it's one of the best results, but if we did 276 interventions, 270 of them went to treatment, and 12 years later, or as long as it's taken, 55% are clean and sober. I don't know if I really believe that number because they're not backed up with drug testing. So that's the number they're getting from those self-reporting when they call up and they get 55%. But I know they've been doing a lot of legacy programs. So during the show, I don't know if any of you saw that, they check in with the person. And when they check in with them like years later, they check in with them and showing how they're doing. So they do have a good success rate. So the intervention show, the drug courts, I believe, are one of the best. They also get an intervention. They get, a treatment plan, 90 days of treatment, continuum random drug testing, 2 years of case management, and the consequences to fail to comply. So that's where I think the 2 major components that we're going to talk about today is the intervention and the case management are the missing links that we don't have in our industry. So if you look at Hawaii, you could do your own research. You know what they are. The drug courts, Hawaii says that they have a 61%. South Dakota says they have a 66%. New York, had a 62%. So, all the drug courts are still higher than what we have. Then we go into the professional enhancement programs for doctors, lawyers, nurses, pharmacists, any high licensed professional. Again, if you look at the recipe, I like the way John Southworth always does it, and it's perfect for what Kelly, what you just bought us. Pat Kelly bought me the chocolate chip cookies. He always says there's a recipe to cook cookies, right? And if you forget something in the recipe, they're not going to be as good. And I know Pat didn't forget something. I'm sure they're delicious. So he always says the same thing with this. Is that there's a recipe for recovery to get the high success rate, and if we don't forget the ingredients, the people will get the better statistics. So the 2 that we've been missing in all these years, from the doctor diversion program, because most people get the detox, they get 90 days of treatment or thereof. It could be with 45 of inpatient and then 45 of IOP and sober living. So however you have to break it up. They're still getting a good group of all this other stuff, relapse prevention, 12-step meetings. But the big 2 ones that they're missing is intensive case management and the intervention. Does anybody know Dr. Skipper, Gregory Skipper? Yeah, some people know him, right? So he did this study, and he was in charge of the professional enhancement program. years ago, and 16 states, they had 79% no relapse rate. I mean, that's huge. 735, physicians in the state, and people are surviving with a 79% success rate. How many of you have that success rate? I mean, I haven't heard of that one. But the difference is, what I'm talking about is the intervention. The licensure, the board, has a gun to their head saying, if you don't stay sober, you're going to lose your license. So that's their intervention. And then they get case management, right? Hello. That would keep anyone. I mean, I would hope that would keep you sober. So that's a huge one. Then we have the airline pilots, right? The same exact thing. The intervention is they're going to lose their license. So they go to treatment for a minimum of 30 days. And then they have everything there, except the difference is they don't have they have the intervention and the case management that, again, the everyday person is not available to them. Anybody know who those two guys are up on the left-hand corner? That's the two guys that were drinking overseas. And you hear of it all the time. But the people that choose to keep their license and be involved with the professional program, their success rate is 92%. 92%. I mean, those numbers are unheard of. So if we're getting 79 to 92% success rate for the people that are out there suffering from this disease, what are we doing that we're not giving to our clients, that we're not reaching those numbers? And the only thing I could come up with, I mean, I've been pounding my head against the wall saying, what are we not doing right? Because when I sit in a living room with a family member and I'm sitting there doing their intervention and I'm telling them, oh, if you do A, B, and C, you're going to get a great chance for long-term recovery. And yet they come out and they end up overdosing and dying. So I don't feel it's ethical for me to say I know what's right for them, and yet they're still coming out and dying. So for 17 years, I've been pounding my head against the wall saying, what are we missing? What are we missing? And what are we missing? And what we're missing is exactly what you talked about, is all of us working together as a team to help these people and continue to have them on that continuum care for 5 years. 5 years. I mean, that's where now when I do an intervention, I don't say, when I first started doing them 17 years ago, I used to say, my job is to get them to treatment. That was my job. Now my job is to educate that family that, number one, they're the ones killing them, and number two, that it's a 5-year plan. That's my job as an interventionist now. So when we look at treat cancer, another disease model, we open up cancer, going into, the different models as how many of you have heard of the 5-year survival rate, right? Only one person? I was like, oh my God. I think everybody knows what the 5-year survival rate is, so why don't we know that for addiction? I mean, when I look at, I always talk about this one because it breaks my heart. When you look at what happened with Whitney Houston, right? Remember the mother did the intervention and she showed up with the court papers here and she said, if you don't go to treatment, I'm taking your daughter away from you. I'm going to CPS. And the minute she heard that, she ran to treatment. Where we fell short is her mother didn't know she needed to hold that over her head for 5 years. That's where we fell short as an industry. We didn't tell the mother that she needed to hold that piece of paper over her head for 5 years. The public thinks, oh, as long as they get into treatment, that's the answer. And that's not the answer. This is why people are dying. They don't understand that recovery is a process. So going back to that other one, it's okay. The cancer treatment, what they have for treatment is in that 5-year plan. It's reevaluate, reevaluate, and reevaluate. Exactly what it should be in our industry, because every single person is completely different. So we need to reevaluate, reevaluate, and reevaluate just like cancer does. So when you compare the addict with cancer, and when they go and get treatment, if I had that little mark, I did have that little mark on the side of my nose. I went into the doctor and I had it biopsied and taken off my nose and seen if it was cancer, right? When it's cancer, people know this is what you do. They don't wait until it gets later like this or the next slide. I know you just ate lunch, so this is what we get when they come into treatment. That's how bad their disease is. We get them when they're that bad. So there's two things that we're missing. We're not catching it in early detection and catching it earlier on, and we're getting people in our beds when they look like this in the disease. If you look at it as addiction is a disease, and we all know it is, and it's treatable, we really got to start spreading that message to the general public that it's 5 years. The minute that a family member talks to you, you just have to start telling them it's a process. Recovery is a process. It's going to take 5 years for them to get into recovery. And if we're all speaking that language, I think that the general public will finally get it in their minds that it's just like cancer. There's a 5-year survival rate, and as long as they're following their treatment protocol for that 5 years, like the doctor diversion programs that we just saw, it used to be 3 years in California, and then they raised it to 5. So also, Dr. Skipper also says that treatment, what we do, is a small part. It's a small part of what needs to happen for long-term recovery. It's not the end all. So when we keep looking at, the treatment centers and we see, what is the criteria to measure success? What is that criteria? I mean, I always like to put it when I work with my families that, recovery is a journey. There's no destination. If you look at this, I just celebrated in July 14th, I celebrated 27 years of recovery, and I'm still working on my recovery. It's not, there is no destination in my recovery or any other addicts out there. If there is, God bless you, because I wish I knew of a shortcut, but I know that every year I have to do something to support my recovery. So 3 or 4 years ago, I went to Pine Grove to their professional enhancement program to deal with the trauma, because when I was a little kid, I was always bullied. And so I never thought I had trauma. I had a great family. My dad was a fireman. We went on vacations every year. I never had any, I was never physically abused, mentally abused, sexually abused. None of that happened to me. So I was like, there's no trauma for me. And going through these conferences, I realized through one of the trauma workshops is that being afraid to go to school every day from 4 years old to 14 is trauma. Every single day, scared to death that I'm going to get beat up again or made fun of, because I was very effeminate back then. I had to practice to get this way. So right now, what I'm doing in my recovery this year, I did Pine Grove for 2 weeks and I stayed 11 weeks, to do some work there. After that, I did Spirit to Spirit up in San Francisco. I did 5 days of a silent meditation. Then after that, I don't know if any of you heard of them, but Laughing Yogi. Anybody here Laughing Yogi? Okay. I had somebody over here heard of him, okay? He would come to my house every day, 3 days a week for a year, and we would do yoga and changing the brain chemistry to laugh when I wake up instead of going into crisis. So again, this was just a year ago. And this year, what I'm doing for my recovery is I'm doing Judy Crane's Spirit to Spirit. And I just finished the third modality, and there's 5 that you do to be trained. So I'm always working on my recovery, it's a lifetime process. But the reality is we got to tell these people that it's a 5-year, because they could wrap their minds around 5 years, because they get the cancer analogy. They get that. They understand that cancer takes 5 years to be cancer-free. So this is what we have to start speaking to people about. 40 to 60% after, drug and alcohol, and this is all from the National Institute of Drug and Alcohol or Addiction. 90 days of treatment is ineffective. And 3 to 7% in 1 year are still sober after 30 days of treatment. I mean, come on, these statistics are what they're reporting. This is heartbreaking that this is all we're giving to people. So we got to change as an industry. We got to change. And I'm really excited because the last 3 years, I've been working hard on figuring out how to make that change and presenting it all with you guys and giving you the tools. So one of the reasons why the statistics are so low is because I would say, if you're like us, 95% of the people are insurance reliant or more, right? Are your people like 95, 90, maybe even higher, right? 95% are reliant on insurance to cover the cost, and insurance isn't paying. We all know that. Insurance isn't paying. So we know the answer, but yet we're fighting with them to get them to pay in order to give them that 5-year plan. So insurance is a big reason why we haven't been able to. So what can we trust for evidence-based statistics? I mean, we all come up with numbers. We all have different numbers. We just saw what the National Institute says that the numbers are. The drug courts, because they're doing random drug testing. You know, they do random drug testing. The the physician healthcare program, they do random drug testing. And the HIMSS program for the pilots, they do random drug testing. So they would lose their license, and those are the ones that I trust that are real statistics. Does anybody know Dr. Scott Hamilton? He runs the Mississippi Doctor Diversion Program out there, and I did a lecture with him a few years back. And I remember I was going in and I was saying that, we need to create healthy boundaries to the families. You know, they need to be healthy boundaries to put into place, because the families are afraid of consequences. They don't like that word. Well, what about my baby? My baby, you can't give them consequences. You know, like that mother said, I can't say no to my daughter. I got to send her stamps. You know, so it's my job, is what he taught me years ago, is that every addict needs consequences, period. How many of your patients came into knocking on your door to check in this past week and said, I just got a raise at my job and a promotion, and I'm getting engaged and I am so excited. Do you have a bed available? Right? Nobody says that. They're like, my wife left me, I hate my job, they're like in so many, in major crisis down here, that we need to create those that rock bottom in order to get them motivated to want to stay in recovery. So consequences is the biggest thing, so you need the stick, but you also need the carrot. Just like the doctor diversion programs. The doctor diversion programs have that carrot, and that carrot is they get to keep their licensure. So the addiction model, recovery model, is intervention. This is the recipe. This is the recipe for long-term recovery. Intervention with the identified person and reevaluate. I've been doing, and I think I'll jump ahead a little bit, because with the case management that we're doing and the interventions that we got Joint Commission accredited on, we've been doing interventions on patients when they're in treatment. And what I mean in that is the intervention is not on the patient themselves. The intervention is on the family system. So we do the same exact thing that we would do at a regular intervention, and we get all the family members on Zoom, and we go over what is going to be their rock bottom. And they're like, Ken, we don't want to do an intervention. They're in treatment. That doesn't make sense. And I'm like, no, the intervention is on you. The intervention is on you because you're the one that's killing your kid. And you have to be very delicate in the way you communicate that, but then you have to hit them like with that 2x4. Because if they're not going to hear us, then they're not going to be able to help save their life. So the intervention is on the family system, on what they can do and what they cannot do. And that meeting, I always say, invite the first 3 rows of a funeral. And what I want to do is I want you to put 4 to 8 hours aside 4 to 8 hours, because we're going to dig deep in this family system and we go over everything. We talk about the family disease concept. We talk about the doctor diversion programs. We talk about, long-term recovery, what that's going to take. And then we talk about how they've been supporting the disease. What have you been doing to support the disease this far? What have you been doing? So we talk about that. And then we talk about how we're going to change our behaviors. And then we put a family recovery plan together. And in that family recovery plan is not only what the addict is doing while they're in your treatment center, but what the family is going to do to get into recovery. Like I told that mother that her daughter just died last week. I told her, I don't want you to make any decision until you go to Al-Anon and you get a sponsor and you ask your sponsor what you're supposed to do. That's when I want you to start making decisions. And do you think that mother did it? Absolutely not. That mother did not do it. And that, in my heart, that's why that young woman is dead. That mother wouldn't do the work. I said, she's going in treatment for 90 days. All I'm asking you to do, 2 hours a week. That's all I'm asking, 2 hours a week. Go to Al-Anon, work the 12 steps, so when your daughter gets out of treatment, you'll be able to speak the same language that she's speaking in recovery. But you need to do at least that, and that mother didn't do it. That mother knew better, and she took her daughter home. The only way I look at this is, because of that happening, instead of her, having her die like that, I want to use that for ammunition. So I told the woman today that texted me about her sister and her mother sending her stamps. I said, have your mother go watch Brittany's episode that was 4 weeks ago. And have her go look on my Facebook page where we're raising donations to bury her daughter. So she didn't have to die in vain. I'm using that for families to see how serious this is. If you don't stop your behaviors, your loved one's going to die. So that's the recipe. So you look at the 5-year plan, you go through it, you have intervention, inpatient treatment, intensive outpatient therapy, sober living if necessary, life skills, recovery advocate, that's case management, we'll go over that, random drug testing, and then of course 12-step support. And 12-step support, I put that in there, that could be many different ways to have support around you. They have lots of different support groups today. It's not only 12 steps, but something where you're staying with peer support. So the 5-year timeline, the intervention, that's the one that we're talking about. And like I said, the intervention is not on the addict, it's on the family system. Every single intervention I do, when they call me up and they say, oh my God, thank you so much for coming in and helping. This is not an intervention on them. Anybody could get them to go to treatment. This is an intervention on you. So intervention is the missing link that we're talking about, and getting a skilled interventionist, getting somebody that really understands the 5-year plan. Because 17 years ago, I was not a skilled interventionist. I was not seasoned. My job was to get that person to treatment. That was my goal, and that was my only goal. But getting somebody that really understands that you're the first person that this family system is introduced to that is going to understand the recovery process. So if you're that first person, you need to give them the information that they need, that it's a 5-year plan. Inpatient treatment, finding the right one. I have somebody that just called my lines today that, it's on a 58-year-old female alcoholic. You're not going to send her to a place with a bunch of 19-year-old heroin addicts. So really finding the right treatment place for her, for each individual, making sure that this is going to be the best possible place for them. And that's what you said, working together. If your place isn't the right place for them, trade cards here, because that's what we need to do, is find the right place for them. So sober living, I always say to our clients, if they want to go home, they go home to a sober living. If there's kids in their community that they need to come home to, they do not go back home to their home. They go to a sober living in their home, in their environment, because that peer support is going to get them connected to the 12 steps or their recovery process. They are not going to do it on their own. They're just not going to do it. We've seen it over and over and over again. They do not do it. What you recommend when they leave treatment, they do not do. So intensive outpatient, another great one. Again, because of insurance not paying for 90 days of inpatient treatment, we have to use this as a tool in the industry. Intensive outpatient, and if you see the timeline, look how small all of this is. Recovery advocate, case manager, random drug testing, and continuum care. This is the other missing link that we're missing. We're not randomly drug testing them when they leave treatment. That's, again, shame on us. They don't understand the importance of doing that. Shame on us. And making sure, let's go back. And then the recovery advocate, so I'll just go over that. So we call it case management, but how many of you that have treatment centers have case managers? Only a couple, yeah. I thought every treatment center had case managers. I hope they do. So every treatment center has case managers. And the way that this gets confusing is when I say, oh, we're gonna do case management on one of your clients, well, we already have case managers. But the difference is we're really not case managers. We're really continuum care coordinators or recovery advocates. We're from the very beginning of the intervention that works through the whole time till the 5-year end of the 5-year plan. That's what we're talking about. The reason why it's called case management, and the other slide before this one, is we have all these different names for it, is because under Joint Commission, we got accredited for case management. Under insurance, they pay for case management. So we call it that, but really it's not the same thing. The case manager, the continuum care coordinator, needs to work with your case managers to make sure that there's a continuum care going through the 5 years, as he talked about. So 12 steps again is, one. So this is the missing link that I think is so important. Continuum care coordinator, case manager, whatever we have to call it, the random drug testing is so important. Without it, we don't really get statistics, without the random drug testing. So that's another really big one that we're missing in the long-term 5-year plan. So the case manager, the way our case managers does is they help develop with the family system a contract, a family recovery plan. So in that family recovery plan, so when I get all the family members, the first 3 rows of the funeral on that screen of my computer or TV, whatever you want to do, does anybody know of Zoom? Anybody know Zoom? So Zoom is like Skype, but they have a HIPAA compliant one. And so when you use that Zoom, you get everybody on the screen and you go over every single thing and you create that license. You create that gun to the head. And every single one of us, if I was to go around the room and ask every one of you, what can you not live without today? You will have one or more things that you would say, I don't want to live without my spouse. I don't want to live without my dog. I don't want to live without my career. There's something that you do not want to live without. Every one of us as human beings have that. When we're doing this and creating that contract, we dig for what that addict's, what their motivation is, and we put it in the family contract. So whatever it is for them, we create that contract, but we also, again, put in the contract what the family system's willing to do in their recovery. So the continuum drug testing, making sure that they're attending their 12-step meetings. Has anybody heard of First Lab that does the drug testing for doctor diversion programs? First Lab or Quest Laboratories. Okay, so Quest Laboratories is where they go and they do their urines, but First Lab is the one that holds the information, and they could either go on their app and or call an 800 number, and if it's their day to test, they have to show up and test that day. So First Lab is really important to be a part of this process. And there's other ones out there. I'm not saying they're the only ones, but that's the ones that we've been using. But they have things where when they're at a 12-step meeting or a doctor's appointment, they check in on their phone, and boom, it's like signing a card at their court card. just like the doctors have to do. So the recovery advocate, case manager, continuum care coordinator, whatever you want to call it, it's up to you. But what they do is they check with the random drug testing, they check with their therapist, they check with the person the addict themselves, they check with their psychiatrist, make sure that they're coming to the meetings, they check with the treatment center if they're still in treatment, the 12-step meetings sponsor, the family system, that's a huge one. They check with everybody in the hub of the wheel. All the spokes, they're checking with them on a regular basis. And they're checking with them once a week. So it's not like, oh, they shoot them an email. They're talking to every one of them once a week to make sure that wheel is still moving. They talk with the individual every single day after they leave treatment. So the 5-year plan is able to use for every single addiction out there, gambling. It's just about accountability. It's kind of like when you have cancer. You get a case manager that's going to work with you, and they're going to stick with you following your recovery plan. But again, every single one needs a motivator. If without a motivator, I mean, just think of it. I have a client right now that's the same client, the mother that wants to send the stamps to. You love this one. She's in Florida. Thank God she's in Florida. It's funny how God works, because she was supposed to go to Miss Brenda's place in New Orleans, or in Louisiana, but because of that big flood that happened, we were doing it when that flood happened, so we had to reroute and take her to Florida. So we took her to a treatment center in Florida, and she knows her family will not put any consequences into place. Like even driving to treatment, on our way to treatment, when we were going to the airport, she was like, my family's not going to do this bottom line stuff. They're not going to do this to me. So she knows they're not going to do that. How many of you have people that are not motivated in your treatment center? Right? If you don't, you're not running a treatment center. So those ones that aren't motivated, we got to figure out what their motivation is and hit it home. So what we did with them is, in Florida, they have the Marchman Act. So all it takes is 2 parents and their clinical supervisor to sign a document to go in front of a judge. So next week, what we're going to do is get the 2 parents to sign it, and then we're going to have it sitting on the clinical supervisor's desk. So if she becomes unmotivated or continues to be unmotivated, then they're going to take it down to the courthouse and give it to the judge, that the judge is going to mandate treatment. And I love this law in Florida. It's my favorite law in Florida. The judge is going to mandate treatment. If she is non-compliant while she's there, then the judge will say, you need to go to jail for the week. And that she'll sit in jail till the next Wednesday when he hears cases, because he only hears them once a week, and she'll sit in jail for that week. And when she gets out of jail, he's going to say, are you ready to be compliant? And if she says no, which I've had, I'm not doing this, I don't care. If the judge mandates 30, 60, or I've seen them mandate up to 120 days, if they say no, that does not go towards the time that the judge mandates towards treatment. So she could spend a month in jail, but that's not going to count. When she gets out, she has to continue with treatment, and she has to be compliant. So I wish, that's one of my other projects, is get that to be a national, law where we could do that in every state in this country, because I believe it saves so many people's lives. That's a motivation. That's like the drug court motivation, but they don't have to break law. We don't have to wait for them to break laws, which we all know they're going to do, in order to help them. So recovery is a seamless continuum of care with many moving parts at all times. We all know that. Everybody is completely different, and everything is moving. So that's why it's important to have that case manager, continuum care coordinator following it through. So everybody needs to start spreading the message, in my opinion, is that we got to start talking the 5-year plan to every family. This is where it gets exciting here, because I've been last time I spoke with Sovereign a year or so back ago, I always present on this one, but this year we have some really good information. on how to make that happen. So case management is the biggest part of creating the family plan, creating accountability, and testing protocols. So has anybody heard in 2020 that our treatment centers, in order to get reimbursed, it's going to be a requirement that we have third-party outcome studies? Has anybody heard that one yet? No? I've heard it. You know, and I was just, you know, with a bunch of payers in DC. We went to go visit an organization that does, what they do in Washington, DC is they're lobbyists for Aetna, Cigna, Humana. So we met with them about 6 months ago. And this is what their requirement, again, they're gonna put more requirements on us in order to get, you know, to make payment. But they're gonna start requiring third-party outcomes in order to pay us. You know, it's gonna be more mandatory for reimbursement. I mean, it's another horrible thing, but we have good news for that. Has anybody heard of Treatment Research Institute? Yeah, good. Thank God. I'm glad some of you heard of them, because they're out in Philadelphia, and I flew out there last December and met with them, and I told them, you know, they've been doing this since I think it's on the next slide. What year is it? 1992, is that it? 1992 they started, and they've been doing this for all these years. And when I met with them in December, they were like, oh my God, Ken, this is the low-bearing fruit that we've been looking for all these years to motivate patients. And it's getting the family system and intervening on them. He goes, it's been in front of us for all these years, and yet we haven't used that in order to get them into long-term recovery. So Treatment Research Institute right now is working with us, and what we're doing is we're creating a platform so it'll be available for every provider out there, that all you have to do is put in the information. Of course, they have to be randomly drug tested with a company. So they have to be able to use that app and make sure that they're really clean and sober. But what they're gonna be able to do is our case managers, continuum care coordinators, or yours, if you have them in your facility, they're gonna be able to go into a database, answer some questions. It's gonna go to TRI, it's gonna be your facility's information, but that's gonna be the third party that's been doing this for that many years. So they're open to doing this for us and holding that data, which I think is incredible for all of us to have that opportunity. So that should be coming out probably in the next 6 months. So really excited about TRI working with us to hold that data, because without it, we're not going to be able to get reimbursed. Got that?
What is the cost for it?
Good question. The cost for that right now, they have a program that I think it's like $1,000 a person, and then it's $35 a month to be a part of this. But what we're looking at is, you know, just like everything else in our industry, the doctor diversion program is what taught us the 5-year plan works. And they didn't do it for the doctor's well-being or the pilot's well-being. They did it to protect the public, right? Same with the drug courts. They did it to protect the public. They didn't do it to save their lives. But what we did is we realized people with money, like we've been doing case management for about 8 years now, and our fee is $18,500 for a year of case management. And people can't afford that. So the people with the money, just like, you know, flying years ago. Remember years ago when I was in the 60s and 70s when I was growing up, it was like a luxury to fly. Now everybody flies. But people with money is what creates standards and creates best practices. So the people with the money for the last 30 years with the doctor diversion program, they've been doing it over 30 years now. And the way I know that is a good friend of mine in Miami, he's a doctor, and he got sober through the doctor diversion program and celebrated 30 years. So they've been doing this for a long time, but they're getting these high levels of success. So the people with money are the ones that are doing this. Our goal after a year of doing this is to go to SAMHSA or to another organization to get the grants and the funding But we need to, again, put it together first and do it for a year. But the good news is that $1,000 and that $35 a month per person is not going to come out of your pocket. You do not have to pay that as a provider, and I'll show you how that happens next. So the two missing links, again, is intervention case management, recovery advocate continuum care coordinator for long-term recovery, and joint commission. How many of you are joint commission accredited? Okay, great, nice. So with joint commission, this year, if you go on their website and you search your treatment center's name, this will be what will come up. So go to the next slide and you'll see these are the different cares or different things that they offer, and the ones that you would want to start picking moving forward is case management, the top one in black, and the bottom, telehealth. So case management is now available as of March of this year, first time ever in behavioral health. So we flew out to Chicago and met with Tracy Collender, the executive director over the whole behavioral health. She loved the idea of the 5-year plan. She says everybody needs it and we got to get payers to pay for it. So she's the one that flew out to DC with us to get the payers to get intervention, case management, and telehealth with a code. So we went out there and we said, so what do you think about case management? And they were like, oh, we love case management. And we were like, oh, good, what's your billing code? They didn't like that. They weren't very happy when they heard that, but they came back with a bunch of billing codes like a month later. So working with Tracy and working with this, you know, she's gonna change where case management, put a slash and have intervention too. So we already got accreditation, and part of it is intervention right now. It's just not on their website yet. So Joint Commission we went to CARF, they weren't interested in doing it with us. So Joint Commission was, you know, gracious enough to say, please come in, we need that 5-year plan and we need payers to start paying for it. So she's the one that kicked open that door for insurance providers. So can we bill for intervention and case management? Yes, as of now, we could start billing for it, and it's on the medical side. It's not on the behavioral health side, so it doesn't take away your benefits while you're treating your patient. So when Pat asked, what is the cost of this? And if anybody wants more information, I don't like retyping things. I'm gonna pass this around so you could, 1962. You could put your name, phone number, if you want more information on this stuff, because this is the exciting part. The other part was so boring, I'm sorry. Hate that part. But this part is so exciting to me. I mean, I am so excited over this. You know, now we are able to bill for this. We're able to bill. We're seeing right now, because since we've only been doing it since March, we're seeing a return of, you know, usually return is what, 40 to 50%, is that right? So I don't even know. We got a 27%, so I don't think our billing company's doing very good. So, but everybody else is telling me that they got a 40 to 55%, but I wish I had their billers. And because I'm getting a 27%. But for case management and intervention, we're seeing right now a 20%. So, and again, it's new, and they got to educate the payers that this is something that they have billing codes for. This is something that has in their policy. When you call them up and you check to verify benefits and you say, do you have case management and intervention? These are two things that are listed under their policy. So we're seeing 80% of the people with PPOs have this, a part of their policy. So 80% of them are able to get the care that we could bill for. So anybody here of Brining Institute? So Brining Institute has been doing this since 1986, and they have credentialing for behavioral health in, I think it's 14 countries and all over the United States. So Brining Institute, we went to them, and my biggest fear with this was, oh my God, we're gonna open up this door, and I know it's none of you people here, but there's a lot of crooked providers out there, okay? Just saying. and my biggest fear was that those people were gonna get a hold of this and they were gonna rip off the insurance companies for case management and intervention and not really giving them the right treatment that's necessary, but just start billing for it. And so we went to Brining Institute because, again, another reputable company that's been doing this since 1986, and we asked them, can you create a credential around case management and interventions? And first they were gonna do just an intervention credential and a case management credential. But after brainstorming with them, really an interventionist needs to understand how to do case management. And again, it's not, I hate the word case management because everybody has a case manager, but continuum care coordinator. So when we realized that, a case manager has to be able to see the red flags and intervene. So when I'm filling out that documentation that's going back to TRI, right, that I'm filling out and answering those questions, that case manager can't just be a data collector, right? I mean, otherwise they're just sitting there filling out notes. But that person needs to be trained for an eye as an interventionist to start looking for, okay, you're not going to your meetings. Okay, you're not, you haven't talked to your sponsor because a case manager talked. Oh, you haven't been going to your therapy. You're looking for the red flags, and then you need to know how to appropriately intervene with the family system. So what we did is we combined the two. So it's a certified case manager interventionist with Brining Institute. So if you go to their website, you'll see that's where it is on the bottom, certified case manager interventionist, CCMI. Again, we are so excited about this because what we also did is because, again, I'm scared to death that we opened up this can of worms and those people that aren't doing things ethically out there are saying, oh, I do case management, but they're not looking for the red flags with the intervention part. The interventionist needs to understand case management because they need to explain to the family system it's a 5-year plan. So you can't just be a case manager or you can't just be an interventionist because you need to understand the process of case management when you sit down. That's the only ethical thing to do, is to understand the whole process. So case management interventionists are combined. So in order to be a CCMI, you have to have some kind of credential in the industry, like KDAC or any other thing above KDAC. 155 hours, pass an exam. So all of that is on Brining Institute's website. And again, if you want any of this, just put your name down and I'll send it all to you guys. The information on this. And then the last thing before I go into questions is I really, again, thank you for being here, but I'm really excited about this. And the one thing that I didn't add, but if any of you are gonna be at the breakers with foundations, we're doing at 11 a.m. Jordan finally gave me the time and date today. So I've been asking Jordan, when's the date? When's the time? So he gave us a room at the breakers to talk about Independent Coalition of Treatment Providers. And what we're gonna be doing at that meeting, it's at 11 a.m. Tuesday of that week during the breakers. And we're gonna get a room and talk about what we've been doing. But the next thing that we're doing, because we started this about 3 years ago at the breakers, where we all decided, let's go to Joint Commission. And then we all decided, let's go to Brining Institute. And then we all decided to go to Treatment Research Institute to hold the data. So the next thing that we're doing, but I don't want to jinx it, but the next thing that we're doing, because the ones that raised your hand that are Joint Commission, I hope all of you get Joint Commission accredited, because right now insurance is saying that they're not going to pay unless if you're Joint Commission accredited. So I like it, and I got Joint Commission accredited 2 months after being open, because I really believe that, why not have that higher standard of care for that person that's out there suffering. But what we're in the process of negotiating with is PricewaterhouseCoopers. Anybody hear of them? So we're negotiating with PricewaterhouseCoopers right now, because Joint Commission comes out and does safety and clinical care. They come out and do an audit on safety and the clinical care. I mean, any of you that went through the audit, I tell them, I said, okay, Tracy, I know you. I got to know Tracy in this time that we've been working together. I said, but still, even knowing you, I felt like somebody was looking up my skirt, okay? I was very vulnerable when they're coming in dissecting our records, if any of you went through that. It's horrible. But they do the audit on safety, and they do the audit on clinical care. What PricewaterhouseCoopers is going to be able to do, again, if we don't jinx this, is come in and do business ethics. Because having them do the same exact thing, but checking out and going under our skirts and checking out our business ethics and what we do in the business. So our hope is that they're willing to do that with us. And then what we've done is we went to those people that are in DC, and we asked them, kind of like right now, when I do PHP at my facility, you know, we need for OP, you need a licensed clinician to see the patient in the groups, and you need a licensed clinician to see the person one-on-one. You know, in PHP or IOP, they don't need to be licensed. They could be KDEC, or they could even be master level clinicians, but they don't need a license. But IOP or OP and one-on-ones, they need to be licensed. So we went to the people in DC, and we asked them, do not pay people that are not CCMI, because, you know, we don't want this industry to do what they did in the past. You know, the industry went and robbed the drug testing. I mean, look at everything that happened there, right? I mean, now, I remember some people were billing 40% of their revenue was from drug testing. So that would have been 40% more lives we could have been saving that could have gotten treatment. You know, the doctor diversion program, guess how much their drug testing is that they get to keep their license with? Does anybody know? How much Quest charges? Quest charges $40 to $80 a test. Drug tests from drug courts, how much are they charging? I think they use a cup, right? So the reality is, if they're gonna keep their license, the convicted felons are gonna get that erased off their record and keep their freedom, and that's all we need for drug testing, then shame on us as an industry. You know, so my biggest fear was that people are gonna go out there and just start billing these services and not really giving the patient what it is, calling that person. So we're gonna have PricewaterhouseCoopers go in and do audits on our case management also, and call those people and make sure that the case manager talk to that person every single day. Make sure that they're talking to that family system once a week. So we gotta raise the standard in our industry for ourselves, because guess what? If we don't do it, guess who's gonna do it? The payers. They're gonna call the shots, and we're gonna be stuck doing whatever they say. But if we could go in there and say, this is what we have, and this is what we believe, because we are doing things ethically and right, I believe that we have a better chance at saving more lives with case management and intervention for every single person out there suffering, because every family needs that.